Hi everybody, and welcome to what we hope will be the first of a bi-monthly Vetruus Bite. Vetruus Bites are bite-sized CPD sessions that last 10 to 15 minutes that we hope you can watch over a cup of coffee with a biscuit, and they're brought to you courtesy of Vetruus. The first of our Vetruus Bites is going to be on anal furunculosis. What is anal furunculosis? It's a chronic, debilitating disease that we know can affect both the perianal and the anal skin, and in some occasions it can affect the rectal skin as well. We know it's an immune-mediated problem, and often we know there's secondary infection. But whereas these cases used to be treated surgically, we now they can now be treated very effectively medically with a combination of both systemic and topical treatment. We know that the German Shepherd dog is highly predisposed to this disease, but we also now recognise it in a whole range of other breeds, such as the Irish Setter and the Labrador, and certainly in our clinics we're starting to see it in such breeds as the American Bulldog. We know most dogs have both cutaneous and bowel signs. The cutaneous signs, of course, can vary enormously, from small pinpoint lesions to very deep circumferential sinuses, which can fill the whole of the perianal skin. We also know dogs can present in a variety of ways. Sometimes they have a low tail carriage, sometimes they will cower, sometimes you'll find that they will lick at their perianal area. As far as large bowel signs are concerned, again, these can be very variable. Sometimes it's as subtle as increased fecal frequency. Sometimes, though, these dogs show an enormous amount of discomfort when they're passing feces. They can strain, and often they will have other signs such as diarrhea and weight loss. And we know to manage anal furunculosis effectively, both the cutaneous and the large bowel signs really do need to be addressed. This next slide, you can see a very severe case of anal furunculosis. There's very severe ulceration and exudation surrounding the whole of the perianal skin. How do we go about investigation of this disease? Well, I think it's very important, because it is a painful condition, to sedate these animals, or better still, to anaesthetise them. You need to identify and examine the anal sacs, as these are often involved, although of course they're not the cause of the problem. They can be full of granulomatous material where you've got severe infection that's become organised within the sacs. We need, of course, to examine the perianal area, and where the sinuses, these need to be explored, particularly where there is the potential they can communicate with the rectum. You do need to do a rectal examination as well. What's also really important is to do some cytology of the perianal skin to identify infection, and where you find this, which you will in almost all cases, you also need to undertake cultures as well. This gives us the opportunity to add in systemic antibiotics if we need to, although often we can manage these with topical therapy alone. If there's any problems where you're unsure that this may be a case of anal furunculosis, then biopsy of the perianal area may also be useful too. In the next slide, you can see we've identified the anal sacs, and we catheterise these, and we tend to keep these catheters in place while we explore the rest of the perianal area. I tend to explore these using a very fine bacteriology swab, so that we can get an indication as to the position of the sinuses and where they actually go to. This next slide, you can see, is cytology taken from that case that we showed you before, and this is a case that has shown a very poor response to cyclosporin therapy, and you can see on the basis of cytology why. We've got a mixed inflammatory infiltrate here, large numbers of highly degenerate neutrophils, and there's also large numbers of bacteria. Hopefully you can see on the sample there's both cocci, large clumps of cocci, probably staphylococcus, and then rods, which may well be something like Pseudomonas. When we're looking at medical therapy, we need to consider both the treatment for the large bowel disease and the cutaneous lesions. For large bowel disease, of course, dietary manipulation can be really useful in many of these dogs. Some dogs will respond well to hypoallergenic diets, particularly some of the hydrolyzed diets. Others will respond better, in our experience, to high-fibre diets. Drugs, of course, can be used to supplement this, particularly if they're showing overt signs of colitis. For cutaneous lesions, we need to identify and treat the infection appropriately, and then once we are happy that we have infection under adequate control, we can then add in immunosuppressive drugs, and we're going to describe to you several different protocols that you may find useful in the management of this disease. There's no doubt that in some cases, when we're looking at infection control, systemic antibiotics are necessary, and I will always, where I can, prescribe these on the basis of culture and sensitivity. But many of these dogs improve enormously with topical therapy alone. Certainly clipping the area and cleansing the area is useful, and we'll certainly undertake this on the occasion when the dog comes in for its anaesthetic, for exploration of the perianal area. Chlorhexidine is my favourite topical product, and because many of these dogs are very uncomfortable, I tend to use this in a spray or a foam rather than a shampoo. For me, the higher the percentage of chlorhexidine you use, the better. So if you have access to a 4% chlorhexidine preparation, this is always going to be ideal. The other nice thing about using sprays and foams, of course, is they're much easier for owners to apply, and I will always prescribe these for home treatment after the dog is discharged back into the owner's care. It may take up to 3 to 4 weeks for infection control to be achieved adequately, and it's important to chat to your owners all the way through the treatment process in order to maintain client confidence. At this stage, though, I'm much more comfortable adding in systemic immunomodulating therapy, and you have a choice of a variety of different drugs. Cyclosporins, azathioprine or glucocorticoids, and then for milder or resolving lesions or for maintenance therapy, we'll often use tacrolimus. I'm going to briefly run through 4 different protocols that you may find useful, and of course the ultimate choice will depend on a wide range of different factors. It may be the dog's tolerance to the drug, whether it develops gastrointestinal signs on it. Of course it may be the cost of the drug, because often we're treating large animals and sometimes we have clients with only limited funds. The first protocol is using cyclosporin alone, and generally the dose range is 2 to 5 milligrams per kilogram, which can be given by mouth, and that's given for up to 16 weeks or until a good clinical response is seen, and then can be tapered to the lowest maintenance dose. The second protocol uses cyclosporin in combination with either itraconazole or ketoconazole, and this can be used to spare the relative dose of the cyclosporin. And certainly you can get away with doses as low as 2.5 milligrams per kilogram cyclosporin with 2.5 milligrams per kilogram of itraconazole. This can be useful to reduce side effects associated with cyclosporin therapy, and also can be useful to keep the costs at a much lower level for clients. The third protocol involves using prednisolone, and this can be used at an anti-inflammatory dose rate of 1 milligram per kilogram. Generally we'll use this daily for 4 weeks before cutting down to half this dose rate and then tapering as quickly as we can down to an alternate day regime. Of course there's the problems with polyuria, polydipsia and polyphagia with prednisolone, but in the German Shepherd dog we often don't find this a big problem. A fourth protocol is to introduce azathioprine. This can be used at a dose of between 1 and 2 milligrams per kilogram, either once a day or every other day. Once though you start to introduce azathioprine though as a steroid-sparing drug, we need to start to monitor, and certainly I'd want to do routine hematology and biochemistry on these animals on a regular basis if I'm using azathioprine. Topical therapy is of course very useful. It's great for cleansing and maintaining antibacterial cover, and then it can be used for maintenance therapy. And certainly tacrolimus, which is available in a cream formulation, can be used daily in the initial stages and then cut down to once or twice a week. So many of the animals that have good remission with cyclosporin or one of the other combinations of systemic immunomodulating therapy can be maintained on, for example, antibacterial sprays or mousses daily, and tacrolimus perhaps 2 to 3 times a week. What of course is hugely important with these animals is to monitor them, and I would like to see all of my cases come back on a regular basis if at all possible, at least monthly. This allows assessment of the lesions. It also allows us to continue to monitor the dog's diet. It also allows us to clip and clean the perianal area so we're maintaining good degrees of anal hygiene, and of course it helps us to pick up any signs of reoccurrence so we can deal with these on an immediate basis. Well, that's the end of our little Vetruus Bite. I hope you've enjoyed it. Please give us some feedback as to how you think these are, and of course if there are any subjects you'd like us to cover in just 10 minutes, please let us know.